So I'm Charlotte Cunningham-Rundles. I'm a physician at Mount Sinai Medical Center in New York City. So let's talk about the burdens of disease that are experienced by our patients with primary immune deficiency disease. And that's the topic of today. And I think it's one that we don't think about very much, which is why we are pointing in this direction today. So first of all, primary immune deficiencies, we have to remember, are genetic. We're not talking about acquired immune defects. We're talking about those that are made in the genes to begin with. There's about 500 that are now known. And of course, all the immune system components are involved. And what goes wrong is that there's impaired maturation or function of different parts of the immune system in each one of those situations. It's funny, we keep thinking they're rare, but actually they do occur in about 1 out of every 1,200 persons. And there's a lot of studies that seem to imply exactly that, coming at it from different points of view. And the other thing I'd like to point out is that we started off thinking that this was something that would really be only affecting infants or babies, for example. But the honest truth is that immune deficiencies affect pretty much everyone, and certainly adults of all ages. And speaking from the standpoint of a person who's primarily an internist, I think this is one of those things that we really have to emphasize. So first of all, what is the immune system? And I think everyone rather knows a little bit about the immune system, but remember that it's a collection of organs and systems. For starting, for example, with the tonsils, for example, the lymph glands in the neck, of course, the thymus gland, the lymph nodes that are under the arm and in the back of the abdomen. Of course, the appendix is effectively kind of an immune organism. There's the bone marrow and the lymphatic vessels. And of course, everybody understands that the spleen is really kind of a very large lymph node and certainly part of the immune system. Now, when you talk about immune deficiency, there's certain things that we might call physiologic. In other words, when a baby is born, the immune system simply isn't matured yet. And so that's just physiological. Also the same thing, for example, with pregnancy or with age. And so these are just a temporal situation. They're not permanent. The primary immune deficiencies, on the other hand, are those that you were born with, for example, as I said a moment ago. And then there's the other types of immune deficiencies, which would be secondary. And that, of course, would be a person who's getting chemotherapy, for example, has had a transplant, for example, or even perhaps if a person is very, very malnourished or has a very number of continuous infections, that might also lead to kind of a secondary immune defect. Now, one of the things that clinical immunologists spend a lot of time doing, and more over the last 30 or 40 years, is to try to categorize those immune deficiencies into pockets. And that's important. When you see a new patient, you have to think, what is wrong with this person? What is going wrong? Can we narrow it down into the portion of the immune system that's failing us? And so these are now divided into somewhere around 10 different pockets here. Of course, we're not going to talk about each of these pockets, but I think most of us understand that there are certain things, for example, severe combined immune deficiency will be a defect of both the cellular and the humoral immune deficiencies. The cells don't work and there's no antibody being made. And that would be severe combined immune deficiency, or perhaps boy in the bubble. And then there's another sort of immune deficiency of the similar sort, except in this circumstance, what you have is associated features. In other words, there's something else that stands out. For example, in ataxia-telangiectasia, there's also some brain abnormalities that occur along with the same. I think the largest group, of course, are the antibody deficiencies, where a patient is simply not making enough antibody, or, for example, not making any antibody at all with this version here, this X-linked agammaglobulinemia. And then increasingly, we've begun to realize that there are diseases of immune dysregulation. So that means where the immune system is not really completely holding its own, because in fact, there's too much of some aspects of immunity because the dysregulation has occurred and it's not being regulated appropriately. And going on down, there are phagocytic abnormalities and then other defects of the innate immune system, which means you don't have to have ever seen that particular bacteria or virus before, but your immune system automatically knows, oh no, that's not good stuff. We don't want that. And moving on down, of course, then there's complement and then bone marrow failure syndromes, and then a whole last category there of things that do in fact occur as an acquired immune defect, except that they look exactly like the types of genetic defects. Now, some of those that I just mentioned, of course, are pretty rare, and some of them are very, very common. So if you wanted to know, for example, which ones would be the most common, which ones appear in the office the most commonly, which ones have gotten, for example, the most industrial commitment, I would say, partly because they are common and they do occur with regularity, and they will be seen in the offices of many doctors. And those would be the antibody deficiency diseases, where it comes in the door as an antibody deficiency, and that's what is obviously wrong. On the other hand, that does not mean that's the only thing that's wrong, but it means this is why that person is really not making antibodies. The second one down here would be the severe combined immune deficiency, and then moving around the pie here are some of the other less common types of immune deficiencies. I think we all know that immune deficiencies give you problems with infections. We understand that. And I think probably most everyone understands that. So one of the things that's really not very well understood is that all these defects also cause what we call non-infectious complications. You might say, well, what is that? It means that it's not because there's an infection, it's because the immune system has lost one of its controls. It's very important to have not only the accelerator, but you also need a brake. And the immune system has accelerators and brakes. And sometimes the brake portion is really not working normally. And that leads to a loss of immune regulation. And the other thing I think that that's been missed for so long is that these non-infectious complications are pretty easy to miss. Because if you're not having infections, then I think everyone thinks, oh, your immune system must be okay. But that's not necessarily true. And one of the problems about the non-infectious complications is by the time you recognize it, unfortunately, there could already have been a lot of organ damage. Many, many things have gone wrong. And of course, that then puts a very, very high burden on patients because they've seen many doctors, hasn't yet been sorted out. And yet by the time it has been sorted out, there's a lot of damage that's occurred. Now let's get specific about that. What are the non-infectious complications? What would those be? Well, the first thing would be autoimmunity, which again seems very contrary. If you can't make an antibody to tetanus, why on earth would you make an antibody to your platelets or your red cells? It doesn't make sense, does it? And I think that's the other portion of things that's so hard to understand. That's because the immune system does control also all of the elements of the immune system, and loss of those controls will give you autoimmunity where you don't want it. Of course, the second one is interstitial lung disease, which is where lymphocytes and other cells have gone into the lung and caused difficulty with breathing. Enteropathy, where the gastrointestinal tract is extremely inflamed, and then you get all this weight loss. Of course, having a very large spleen, having large lymph nodes, all of these things affect growth and development, such as this child here, who's very, very small. And the reason why is because the immune system is really, really not doing a very good job. Very severe eczema, for example, autoimmune disorders, of course, cancer, fatigue, depression, and unfortunately, early mortality. And these pictures just give you a quick picture of some of the things that I've just mentioned. Now, one of the targets, of course, as you might imagine, of course, is the lung disease. And some of that, of course, is infectious. That's going to be pneumonia, but a lot of it is not infectious necessarily. And so what are the pulmonary diseases and where do they occur? This top one here, of course, is an antibody deficiency. That's called common variable immune deficiency. I know it's not a very illuminating name, but patients with that particular immune defect don't make antibodies very well. Also, pulmonary disease occurs in pretty much every one of the immune deficiencies that I had on that first slide. Now, when I say airway disease, that means it'll look a little bit like asthma, but it might or might not really be asthma in the classic sense. And then, of course, there's lung tissue disease, which means that some of the cells that do not belong in the lung have migrated into the lung. And that, of course, gives shortness of breath and then ultimately damage to the lung. Now, you could quickly imagine with that much lung disease on the past slide, you could imagine that patients are really going to the doctor a lot, and they're having many, many procedures and treatments. And I like this slide because Dr. Prevalence went to the effort of actually categorizing how many procedures had to be done in 392 patients. And as you could see, a good number of them had to have a tube down into their lungs, a bronchoscopy, had to have a lung biopsy, had to have some surgery on their lung, had to have a chest tube placed, and then, of course, a great deal of treatments for lung disease as well. So it's something that brings you to the office a lot. It's very similar also with gastrointestinal disease, as you might imagine. And that slide was again put together by another group of investigators looking at, in this case, 110 immune deficiencies, trying to say, well, who's having all the gastrointestinal disease? In this particular case, it was really quite evenly spread against most of the immune deficiencies, starting with the one with the syndromic features, but then moving on down with those cellular and humoral immune defects, just moving on down, pretty much every single one of the immune deficiencies was having quite a bit of gastrointestinal disease. And again, as I said before, this would create the need for many, many procedures. One of the other points to make is that patients don't feel well and they complain of fatigue. And it's easy to understand why, with all the things I've just mentioned, all these complications. Depression is common, but most people would be depressed, for example, if they can't breathe and they're having diarrhea and their GI tract is misbehaving. And there's also some bronchiectasis, which means scarring of the lungs. Lymph nodes are very large, the platelets are low, the spleen is big, and then, of course, cancers of various sorts. So moving down the list, you can see that all of these things would easily lead to both fatigue and depression. And Dr. Hajar actually put this data together to really come up with some actual numbers about what patients will tell their doctors. And as you can see, it's a heavy burden as well to be fatigued all the time, not able to go to work or to go to school. And mortality, of course, is the other side of the coin. And this actually is the National Center for Health Statistics research, which was again put together by Fernandez Perez et al. And as you can see, that there's quite a bit of mortality pretty much in every one of the pockets of types of immune deficiencies here. So this causes early death is the problem, and partly because the diseases were not recognized on time. And in some cases, because there was infections that could not be combated, as you can see on this slide here. For example, bad infections that could not be combated, respiratory failure, for example, cardiovascular failure, one way or the other, endocrine or metabolic defects, and of course, malignancy as well. So these are the issues that we have also in our patients. Now, speaking about one disease that I've worked on quite a bit, and this is data from our particular medical center, is that when you look at common variable immune deficiency, the first thing you think of is, well, they're not making antibodies, so certainly they all have infections. Okay, many do, most do, in fact. The catch is that most of our patients have something additional, and that's what the other complications are indicating here. In other words, 25 or so percent, I guess I have on this slide, 24% of our patients have had autoimmunity. And usually that's low platelet counts or, for example, hemolytic anemia or rheumatoid arthritis, some other autoimmune condition has occurred. Many of our patients have lung damage. They have lymphoid hyperplasia, which means the spleen is very big. Quite a bit of gastrointestinal disease giving weight loss, and lots of gastrointestinal complaints, a lot of liver disease. And moving down the list, about 5% of our patients have actually had now a lymphoma. B-cell lymphoma in the most usual cases would be the type that occurs. But this is the data that everyone reports from common variable immune deficiency. That's not just our own data. And the other thing to mention, of course, as I mentioned, gastrointestinal disease, and you might say, well, tell me what exactly is going wrong. Well, it's true that in some cases you have parasites and bacteria. That's true. But you also have viral infections. But then the next thing is something called nodular hyperplasia. For example, this particular man lost somewhere around 100 pounds. And this is actually the inside of the gastrointestinal tract, which is so swollen with lymphocytes that have so swollen that he has no absorptive surface, and he's lost a lot of weight on account of that. The second slide is a picture of a patient of ours who has Crohn's disease, because again, very much inflammation has occurred in the gastrointestinal tract. And so that's this particular situation. So we have celiac disease, Crohn's disease, and ulcerative colitis. And all of these, again, do occur in our patients with this particular problem. I think one of the things that we understand really extremely poorly, and again, we have quite a few patients with this particular problem, which is liver disease. And I don't have an explanation for that. It's not infectious. It certainly is not infectious. But there is an ailment called nodular regenerative hyperplasia, which means the liver becomes stiff and it really can't allow the portal blood to flow through in the normal way. Because of that, you get increased portal blood flow, and then that makes the spleen enlarge, and then the spleen becomes big, and then there's more splenic hyper reflux backwards into the portal system, and then the liver has to absorb that extra pressure again. What does that do? It gives you a large liver, gives you a large spleen, gives you portal hypertension, hypersplenism, which means that some of the platelets and the red cells are taken out of the blood way too quickly, and that leads to anemia. And the whole thing leads to lack of normal liver function, which will be a coagulation defect. And some of our patients have required then a liver transplant. And that's all because of this immune dysregulation. It's not a question of infection here. So looking back, if you look in some of the other registries, because I think registries give you the big picture sometimes. If you look at the European Society of Immune Deficiencies registry on common variable immune deficiency and say, what are some of the comorbidities and what are the mortality in that particular set of patients? And this is a large number of people who did not survive. And as you can see, lymphoma occurred, solid tumors occurred, but also then lymphocytic lung disease and very large spleens and autoimmunity, enteropathy, cytopenias, and bronchiectasis. So all of these things are saying the same thing. We all see the same thing in our patient groups. And it's not because the patient is not getting gamma globulin, not getting antibiotics when required. It has nothing to do with that treatment. Those treatments do not help. And of course, that leads to a calculation that the average rate of years lost to premature death in these patients with common variable immune deficiency is really very substantial. And that you can compare with the general population pretty much in every single age group, if you notice. It's really rather dismaying to realize, how poorly those patients manage to do. So I think one of the curious things, you have to step a big step back and say, why do you have all the complications? And if you go back and you say, well, more and more, we understand that some of the genes that control the immune system, if they are defective, that means this intense conversation that's taking place between the T cells and the B cells is failing. And all of the areas which are marked in red are genes which we now know, when defective, will then lead towards dysregulation. Lack of antibody, for example, also lack of appropriate T cell activation, or too much T cell activation, or T cells that become activated at the wrong time and in the wrong way. And so because of this conversation is completely abnormal, this is one of the reasons why we see this uncontrolled inflammation. And so much of that, as you could see from what I said about the lungs and the gastrointestinal tract, that's primarily the mucosal and the barrier areas, the GI tract and the lungs being really very predominant. So these are some of the things that we have to take into our understanding of the medical world, which is that these are the defects that are getting to be very, very important. And they really create great burdens of disease in primary immune deficiency. Now, more and more, we understand that the genes that lead to primary immune deficiencies are getting discovered at an increasing rate, up to now 500 in the most recent publication. But they lead to all this in non-infectious complications as well as infections. And the interesting thing is that the complications do evolve. In other words, they are not necessarily present on the first patient encounter, but they may appear within the next year or the year after, or the third year, or over time, more and more will be likely to appear. And that leads to many, many medical interventions, of course, organ damage, loss of life. And for all these reasons, what we have is the situation of we really have to recognize these immune defects much earlier than we are doing now. And another reason really is not only that you know that that immune defect is present, but you probably realize that biological therapies are emerging rather rapidly. And some of these immune defects can be having very, very targeted therapies. And these targeted therapies are exactly what is ordered, what is needed for the correct therapy of those patients. And I'm absolutely convinced that there'll be additional therapies that are going to emerge with time. I think for all of these reasons, it's really important for physicians in all the specialties to really talk with immunology, collaborate with immunology, because we perhaps may give a little bit of insight, hasten diagnosis in particular, and hopefully come up with some better and a little bit more insights into what we can do about improving care. So thank you very much, and I hope these conversations and this outline will be of use to you. Thank you very much.